keep bugs out, guaranteed.
You can tell a provincial election is coming this fall. Senior cabinet ministers are making the rounds with checkbooks in hand.
Case in point, Health Minister George Smitherman. He dropped by Hamilton this morning to announce that his government is renewing health care with a 28.3% increase in funding that enables hospitals to deliver shorter wait times, more access to doctors and nurses, and provides more critical health services. Good news, but cold comfort for many chronic care patients in and around Steeltown.
You see, the province only pays for certain types of pain care, so doctors have been sneaking uninsured patients into their pain management programs for free. But with waiting lists spiraling to 3 years, Chinook Hospital limited its program to those with private insurance or those injured on the job. So their care is paid for by the Workplace Safety and Insurance Board. And that has left many people having fallen through the pain care cracks.
We are joined by Dr. Jeff Ennis, a psychiatrist who specializes in pain management and director of the East End Multidisciplinary Pain Management Program. Beside him, Feather Glover, a chronic pain patient herself who helps run pain support groups. Dr. Ennis, what exactly does OHIP cover and not cover in terms of pain management?
It's an interesting question. There's actually no, for me at any rate, I can only speak about my specialty, there's no specific coverage for pain patients specifically. So my coverage is for any patient, whether it be a pain patient or someone with other problems. There's no coverage for the development of a program, however. So my time can be covered, but all the things that go into creating a full, what's referred to as multidisciplinary pain program, there's no specific coverage through OHIP.
Can you explain what you mean by that multidisciplinary program?
Sure. First of all, what we're talking about are folks with chronic pain, and people with chronic pain can come from various different avenues and places to get there. They may be people with work-related injuries, people with diseases. It's like the Hair Club for Men. I'm also a member of that population. I'm just recovering from a back fusion surgery that was done at the end of February, as we speak. So how you get to this end point of having chronic pain is variable, but it shares many problems. Chronic pain can lead to destruction of your life, family, the things you enjoyed to do before, your work, what you feel like, who you think you are. So that's the population of people. If we look at what's helpful for these people in terms of treatment, by the time they see a fellow like me, they've had pretty much every treatment we can think of, and that can include surgery, it can include use of medicine, it can include intervention, which is often from our colleagues in anesthesia. So my job is to help people live with what they're left with, and have as good a life as possible. In order to do that, multidisciplinary pain programs have been found to be the best way to go, and that means exactly what it pretty much sounds like, the use of various disciplines, disciplines, putting together their skills to help people in my boat and in Feather's boat to be able to do more in spite of the pain that they have.
All right, let's ask your patient. Feather, what happens to chronic pain patients who don't learn or haven't learned to live with their pain?
Well, I can speak for myself. Until I met Dr. Ennis, I was just sinking into a big black hole of depression. I was completely isolated. You know, I had friends that came around to visit, loyal friends, but they couldn't understand what was happening to me because I didn't understand myself. So unless you have the validation of belonging to a pain group with other people that are in pain, you just feel like nobody gets it, nobody understands. Right.
In these pain support groups, give us an idea of what's talked about and how it's dealt with.
There's a lot of emotional stuff that's talked about. I've seen people break down and cry just knowing that you know they're not losing their mind because your memory's affected. The pain is a distraction. You learn, you know, different exercises and the importance of exercise to help keep you going, because that's really important.
Dr. Ennis, we mentioned earlier that the programs themselves are not covered by OHIP, correct?
Correct.
But are the treatments in terms of drugs or physiotherapy and that, they are covered, correct?
Well, it's an interesting question. You may want to ask a physiotherapist about that, because in the process of changes in our health care, the majority of physiotherapy programs available to us folk have disappeared.
So what is the problem? Is the government simply saying, hey, it's not killing you, so therefore deal with it? Is that pretty much it?
I don't know. I don't know what the government's saying. Maybe a lot of people think that way. I know that it's not a priority, though. No one's knocked on my door and said, listen, Doc, we have some monies here. We can help you run this program. We've been very fortunate. In some ways, we've had a bit of grant money from one program in the city, the HSO Mental Health and Nutrition Program. So that's been helpful. But for the most part, we have many patients that do not have access to insurance, and effectively what I'll do is I'll bring them into my program anyway. I've never turned down a patient because of funding issues. I just don't think it's a high priority for anybody.
Sorry, Donna. Feather, I want to ask you about, you mentioned depression before that. And a lot of people, when they hear that, they say, well, that's something that's, you can deal with it through, through drugs, whatever. Pain and depression together. How difficult is that to handle?
It's really difficult, and I think, like I was saying before, just being around other people that are in pain, it's like someone with an alcohol problem going to AA. It's the same sort of thing. You're with other people that understand, so it helps you to cope better.
Right. And from a doctor's standpoint, Dr. Ennis, can you tell us about pain and depression and what you need to do as the physician to these patients?
Sure. I mean, you have to realize that for the typical population, about 10% of people will have depression. In the pain population, over 30% will have depression. So the numbers go up big time because there's a strong physiologic connection. The problem is that it's a deadly combination of pain and depression. The risk of suicide, unfortunately, is quite high, and it's a diagnosis that's often missed. And I think it's very similar to cancer patients in that often people figure, if you have cancer, if you have pain, I'd be depressed too. And so it's really ignored.
So what's the solution? Do we have to lobby the government for funding, or just at least acknowledgement that depression and long-term chronic pain is something serious and has to be dealt with?
I think it would be nice, at least in my world, if it was taken as a serious problem, if funds were made available for a place like Shadok Hospital to open its doors back up to folks with, who are OHIP funded, who could provide fellows like me with funds to be able to help the program I have, and if there are other good people out there, that would be great. And the second part has more to do with physician education in terms of recognizing that depression, along with pain, is a serious problem and needs to be treated.
Right. Folks, thanks so much for joining us. Feather Glover and Dr. Jeff Ennis, we appreciate your time, both of you.
Pleasure.
Thank you.
Thank you.